So as a clinical psychologist, obviously at some point you must have run some treatment groups.
Yeah.
Can you tell us a little bit about some of the treatment groups you've run in forensic settings?
Yeah, so treatment in forensic settings, whether it's in a forensic setting, in an inpatient service, a secure service, or in a community service, tends to be a mixture of individual and group work.
Yeah.
There is a sort of tradition of group work with offenders, and a lot of that is about setting the conditions for offenders to be able to challenge one another's cognitions and behaviours and ideas, really. And that's more powerful coming from another offender who's been through a similar set of circumstances than a clinician who's perceived as being very socially different to the group. So there's not more magic to it than that, really. That's really, I think, one of the key active ingredients. And you get more sort of grist for the mill, really, in a group. There's more stories, more cognitions, more behaviours, more things to talk about. I've been involved in running sexual offender treatment programs for people with severe mental illness and who have sexually offended, sexual offender treatment programs for people with intellectual disabilities. Fire setting treatment programs is another thing that I've done, particularly with people with intellectual disability. And then there's a sort of suite of kind of social problem solving programs that are designed really to target that kind of criminogenic thinking style. So that sort of antisocial approach to life where, you know, if you've got something I want, then I can punch you in the face and get that, and that's my needs met. That's a very different kind of treatment group, really, because it's much broader. You're talking about situations that are have got a much greater breadth to them. So there are a couple of very well researched, good evidence-based programs for those that I've also been involved in.
Okay. So with these programs, who does them? Do they volunteer, or are they made to do these programs?
Yeah, it's a very good question. You can't make anybody do psychological therapy, but there is a big question of coercion, sort of implicit coercion, I think. So you could say the same in the prison service, I guess, that if somebody, it's not uncommon for somebody to be told, you know, if you want your parole hearing to go well, then you've got to have done your sex offender treatment program or your reasoning and rehabilitation program, which is the kind of violent cognition equivalent. It's a little bit different in a mental health service in that it's treatment, and the whole program is treatment. You've often got time on your side, so you can wait for people to make some kind of self-informed decision that they're going to attend. But nonetheless, in the back of everybody's mind is the implicit contract of being in a secure service, which is, we've got some treatment, you do the treatment, then you can go.
Okay. And so the goal of people who do these programs is actually to get better, if you want to phrase it in that way. They want to achieve a change in their behaviour.
I mean,
is that
again,
the therapist's goal?
So the motivations are mixed. I think people have got mixed motivations, and their reasons for being in the treatment program probably ebbs and flows over time. Certainly the service, which represents the government, which represents the community, have a vested interest in people engaging in the treatment program. There isn't great evidence that you can still be in denial about having committed an offence, do a sex offender treatment program and gain some benefit from it in terms of reduced recidivism rates. So it's not an absolute requirement that you kind of go in, bare your soul and magically gain some insight that prevents you from reoffending. There's a much broader set of active ingredients, but I think that people's motivation is mixed, and underneath it all is, if I do this, I'll get out. And some people believe what they did was wrong and hurtful, and other people to a lesser degree.
And with these groups, you said there's a lot of group therapy here. So how are these structured? Is it always nice and pleasant, or does it, I mean, I'm trying to get an idea of the dynamics of these groups.
Yeah, you don't want it too nice and pleasant. I mean, you try and set the dynamics so there's a little bit of I guess it's like stretching a rubber band. You know, you need enough tension in it for it to be able to do its job. So you give people a lot of warning. What you tend to get in a treatment group is a sort of active phase. You have a kind of build-up phase, and then an active phase, and then a phase that's about people getting the what's next
Yeah.
part discussed and sorted in their head. And it's the active phase in the middle where people are discussing their offence or an offence. Often there's multiple offences.
Yeah.
You encourage people to pick one offence and that gets discussed in an enormous amount of detail. So there's quite a lot of build up to that.
Yeah.
So the group can start off fairly low key, I guess, and you're just exploring general kind of CBT concepts, getting the group bonded together, talking about factors that sort of affect everybody's propensity to reoffend, you know, drug and alcohol use, that kind of thing. But at some point you get to the sharp end, which is individual members talking about what they did and then other group members asking them questions about it. And that for each person can take 3 or 4 weeks. Each individual's active account can be a 90-minute session or longer over 3 or 4 weeks. And so it's pretty punishing. And what you often get in services, what you have to manage as the clinician running the group, is all the dynamics that happen outside of the group.
Right.
So people disclose their offence in a group, and then in an inpatient service, they might go back to the ward with other people in the group. And so there can be tensions outside of the group that have got their genesis from within the group. That causes tensions on the ward, which makes service managers, nursing staff anxious about the group. And so running a group successfully in an inpatient service, a lot of it's about managing the whole system rather than just the 90 minutes in the room.
I guess a lot of people who are not clinical psychologists would consider that they might feel kind of at risk themselves if they were to run such a group with, with people in forensic settings.
Yeah.
Have you ever felt at
No,
risk?
I mean, there's a kind of vicarious trauma aspect to it sometimes. Clinical psychologists, like any health professional, tend to go into roles that they are sort of implicitly comfortable in. So in terms of the day-to-day stories that I hear, they don't give me a great cause for concern. No, I've never felt directly at risk. Sometimes in a group you're trying to manage, it gets the blood pumping. So if clients individually fall out with one another and someone storms out of the room, then you need a bit of experience to deal with that, and the service needs to be ready for it. And it's why you tend to need more than one therapist in the room. Not really for risk to you as the therapist, but if someone leaves very unexpectedly or in a state of distress, then you don't want to leave clients by themselves. So I've never felt directly at risk, and I've worked in sort of medium and high secure services. There can be a vicarious trauma element. Sometimes the stuff you hear can be fairly graphic and upsetting, I suppose, and you kind of hear about people that have been quite seriously harmed or murdered. I would say some of the more kind of anxiety-provoking situations that I've worked in tend to be working with clients who are in the community. You know, if you're working in a forensic, if you're working in a forensic service, they're all about managing risk. And at the end of the group, everyone goes back to their secure ward, and there's people there that can help them if they're under distress. If you're running a group in a community, then at the end of the group, people go back to their lives. And so there's an element of having to manage the group in that way. You know, you have to keep everything a bit more contained, I suppose, because people can't be leaving in such a quite high state of distress. But also, you know, you drive home from the group in the afternoon or at night thinking, well, these people are at large. And so I find that the most challenging from a kind of personal perspective. It's working with serious offenders who are in the community.
Okay. So I guess one of the other common perceptions, and one that we see, I guess, in popular fiction at least, is this notion that people fake it in therapy groups in order to get out and reoffend. Is that possible? And does it matter?
Yeah, they're two different questions. And I think, is it possible? I think the first question is, do people try? So yes, people do try, I think. Not necessarily purely from I'm going to fake my way through the whole of this. I think, you know, I try and understand it from a more psychological perspective. So often that sort of need to try and fake it, as it were, comes from the fact that they don't want to sit there and talk about the child they raped in front of 5 other people, 6 other people, and that's understandable. So some of the early phase of a group is trying to break that down.
Right.
So it's not uncommon to have a group with people in it who are more defensive, for example. It's pretty hard to fake it all the way through. I mean, people go all the way through in quite a disengaged way, but you tend to be able to pick that up as a therapist. But, you know, I'm sure there are expert clients, patients, offenders out there who are very good at telling clinicians what they want to know, which is why what you're trying to look for other information, collateral information that confirms or disconfirms what you're hearing in the group. So if you're working in an inpatient secure service, for example, you're often looking for offence mirroring behaviour, offence analogue behaviour.
What are they?
Well, so if somebody is in a secure service for stalking,
Yep.
and they're talking about that in what appears to be a very kind of effective manner in the group, and in the group you feel that you're making progress, there's evidence of change to their cognitions,
Yep.
but back on the ward they're sort of engaging in predatory type behaviour, either with other clients or other staff, and it might not be overtly predatory, but it might be quite sort of I guess masked behaviour, like just being seen always looking at the same person, always following the same member of staff around, ingratiating themselves to certain people.
Yep.
You're always looking for small signs that are evidence, as I said, that confirms or disconfirms what you're hearing in treatment groups and other treatment sessions, in individual sessions, in other people's clinical work.
So I guess that's where you get, again, one of those key differences between those people in the community, because you don't have access to that knowledge about them.
You don't see that, and so what you see is what you get.
Yeah.
Really, whether it's an individual session or a group session.
Yeah.
Yeah. So you don't have the same richness of clinical material at all.